There will be difficulty in surviving.
I think sir, Lucknow has also many now because of.
To all eminent faculty members and participants who have joined from various parts of India and abroad. Welcome to this live webinar. I am Sumit Kumar Madan from Zydus Life Sciences Limited, and on behalf of Zydus, I welcome everyone. Today we have got two talks, and I welcome our guest speakers for the evening, Dr. Monarch Vijayaran from SGPGI Lucknow and Dr. Jardin Febres from France, all the discussants and participants. So first topic is inborn errors of immunity in hematology, and second talk would be on ctDNA and lymphomas. Before we commence the proceedings, I would like to welcome and introduce the host and convener for this continuous medical education series under the edges of Mumbai Hematology Group, Dr. M.B. Agarwal. Sir is Professor and Head Department of Hematology, Bombay Hospital, Institute of Medical Sciences, Mumbai. He is also associated with other esteemed institutes like PD Hinduja Hospital, Leelavati Hospital, Fortis Hospital, and Breach Candy Hospital in Mumbai. He is the president of Mumbai Hematology Group as well. I request Sir to navigate this program further. Sir, over to you.
Thank you, Mr. Sumit, for that kind introduction and for supporting our academic activities. Before I begin this webinar, just for those who have logged in on a Thursday for the first time, the MHG webinars have moved from Saturday and Sunday to now Thursday evenings. We'll be having 2 lectures every Thursday, 1:30 and one at 7:30. So just take care. The attendance has gone up almost 3-fold. So I think this is much more convenient to everybody than what Saturday, Sunday was, which now has become a family day rather than to spend on the academics. So with that, good evening to everybody from India. And as Mr. Sumit said, good morning and good afternoon to those who are logged in from other parts of the world. So first speaker is Dr. Mona Vijayaran from SGPGI Lucknow. And our second speaker will be Jardine Fabrice from France. Dr. Mona Vijayaran will be speaking on a very interesting subject which we are covering for the first time in these webinars, that is inborn errors of immunity, popularly known as IEI, in hematology, interplay, and recent advances. So I'm personally very excited to listen to this subject. These webinars are brought to you by MHG. This one is supported by Zydus, who have been our regular partner, and managed by Perfect Square, who have been managing all our webinars for last 6 years. I thank Mr. Sumit Madan, Mr. Ashish Kumar, Mr. Rajesh More, and the team Zydus, Mr. Yash, Mr. Kalpesh, and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speakers today, all our discussants were themselves eminent hematologists and medical oncologists all across the globe, and you participants for sparing your Thursday evening once again from all across the globe. A flavor of next Thursday, 21st of May. 6:30, we have Professor Dr. Pranta Chakravarti. We're going to speak on another very interesting subject, and that is artificial intelligence in hematology, friend or foe, and I hope it is friend. Following that at 7:30, we have Dr. Gaurav Dikshit from Gurgaon speaking to us on the changing treatment paradigm of chronic lymphocytic leukemia. You'll all agree the treatment of CLL has changed by leaps and bounds, and he's going to discuss from continuous to time-limited therapies. A brief introduction of our speaker, Dr. Mona. She is Assistant Professor, Department of Clinical Hematology, SGPGI, Lucknow. Beyond this introduction, I must tell you that she is a brilliant person, brilliant hematologist, and I've seen her in these webinars for last 6 years, and recently I had an opportunity to even listen to her in person. She has completed her DM in clinical hematology from AIMS, Delhi. She has trained and worked at King George Medical University, Lucknow, Safdarjung Hospital, and VMMC, Delhi, and Artemis Hospital, Gurugram. She has over 10 years of experience in managing pediatric and adult hematological disorders. Her areas of interest include acute leukemias, hematopoietic stem cell transplantation, and cellular therapy. She also has been a keen interest in inborn error of immunity and histocytic disorders, and that's why the subject today. And she's going to speak to on IEI in hematology, the interplay, and recent advances. Well, thank you so much. With that, I will stop sharing and request Dr. Mona to take over.
Thank you, sir, for this kind introduction. I'm going to. Sir, is my screen visible, sir?
No, not yet.
Sir, is it visible now?
Yes, perfect.
Okay. Good evening to everyone present for this webinar. I'm going to speak on inborn errors of immunity in hematology and the interplay and recent advances. Recently, in the last year and this year also, there has been an increase in awareness regarding how immunology and hematology are interlinked to each other, and there has been focus symposium even in the European Society of Immunodeficiency, and this currently in this year's EBMT also. So the inborn errors of immunity is expanding continuously year by year. And from 1990s to 2024, every year we see many, many more monogenic entities are described, and we must keep pace as hematologists. So currently, there are 508 monogenic inborn errors of immunity. 67 of them are novel defects added only in 2024. These defects are updated every 2 years, and there are 10 categories to this classification. Coming to the classification, the 10 categories are: the first is combined immunodeficiency, for which are present as early severe multi-organ infections. The prototype example is SCID, for which an early transplant is required, and it is referred to a pediatric hematologist. Second is combined immunodeficiency with syndromic features, viscotalric, and then it presents with eczema, thrombocytopenias, and it is managed mostly by transplants. Third is predominantly antibody deficiencies, common variable immunodeficiencies, and it presents with recurrent sinopulmonary infections. Fourth is of main concern to the hematologist, diseases of immune dysregulation, CTLA4, LRBA, ALPS, STAT3 gain of function, because they present with autoimmunity, cytopenias, and lymphoproliferative disorders. Fifth one is phagocytic defects, chronic granulomatous disease, severe congenital neutropenia. They present with abscesses and frequently require transplant for CGD. Sixth is defects in intrinsic and innate immunity, and unusual infections are present in the healthy hosts. Seventh is autoinflammatory. They present with recurrent fevers and inflammation. Eighth is complement deficiencies. They also present with encapsulated bacterial infections and autoimmunity. Ninth one, which we are more familiar as hematologists, is the bone marrow failure group, which encompasses Fanconi anemia, DKC, which presents with cytopenias, cancer predisposition. And the 10th one is phenocopies of inborn errors of immunity, which have somatic mutation and present with adult onset genetic-like diseases. So out of these 10 categories, we have patients referred to hematology, likely from the fourth group and from the ninth group, but we usually have transplant indications from many other groups. So when to suspect inborn errors of immunity, how to recognize them? So going through this case, you will see how a typical patient of inborn errors of immunity present with hematological manifestations. So we are talking about this 12-week-old child who presents to the pediatrician with AIHA, splenomegaly, refractory ITP, and has from 2 years of age starts having recurrent staphylococcal infections. From 4 years of age to 16 years, he has this reactive lymphadenopathy with arthritis and colitis, and a genetic diagnosis was established around 4.5 years of age. He is refractory to IVIG steroids, and next, at around 18 years of age, he develops a classical Hodgkin's lymphoma. He receives treatment in the form of OEPA, COPDAC, and then relapses, receives ESHAP as a salvage regimen, and then receives an allogenic hematopoietic stem cell transplant. It is highly unusual for a patient of relapsed classical Hodgkin's to go for allogenic transplant. But because the patient has underlying immunodeficiency, so it was the good decision to go for allogenic transplant, and the patient is alive and well. So the genetic diagnosis was for this patient was ALPS, which resulted in defective apoptosis. And this scenario is a typical scenario how a patient of, when we see the patient of classical Hodgkin's lymphoma in a clinic, if a history is suggestive of recurrent infections, autoimmune cytopenias, then we should be highly vigilant to suspect such disorders. So again, summarizing that any patient who has severe recurrent unusual infections, failure to thrive, has a family history, requires frequent IV antibiotics, recurrent deep abscesses, has BCG complications. On CBC, we see persistent lymphopenia, presence with HLH, has chronic diarrhea, should be suspected for inborn errors of immunity. The single trigger for a hematologist is a combination of cytopenias, unusual infection, and lymphoproliferation. So I would be taking ahead this talk based on the 6 basic categories which we face as a hematologist. First is autoimmune cytopenias. Second is polyclonal lymphoproliferation. Third is lymphoid and solid malignancy, bone marrow failures, and HLH and HLH mimics, and eosinophilia. It does not say that only one set of presentation is limited to one disease. One gene can have several faces. Like a patient with ALPS, CVID, can present with autoimmune cytopenias and malignancy simultaneously. Patient with Viscott-Aldrich can present with eosinophilia and a malignancy or autoimmune cytopenias. So one gene can have multiple presentations occurring simultaneously or sometimes years apart. So coming to the first aspect that we see as hematologists is autoimmune cytopenias. This is the most common manifestation. Starting with the case. So we have here is a 1-year-old male who was diagnosed with Evans syndrome with poor response to steroids and IVIG. Because he's a young patient with a refractory cytopenia, a next generation sequencing was sent, and it showed a pathogenic variant for STAT3 mutation. So along with immunologist, we started tofacitinib, 3.2 mg as for his weight, and the patient achieved good remission after this. And he continues to be on tofacitinib. It's 1.5 years post starting tofacitinib. He's doing well. So now coming to the general aspect, that the red flag signs as shown by the case, multi-lineage cytopenias, when there is no clear drug trigger, refractory ITPs as this patient had, and also having lymphoproliferation and granulomas, then we should suspect the underlying inborn errors of immunity. What are the common autoimmune inborn errors of immunity which present with autoimmune cytopenias? As we can see, ALPS is 52 to 70%, ctLA4 is 62 to 68%, LRB is 70%, and STAT3 gain of function is 67%. There are many others who can present with cytopenias like Viscott-Aldrich, which causes microthrombocytopenia, AIHA. So these are the various diseases that we suspect when we are dealing with a patient of autoimmune cytopenias. So a broad approach is the workup we send is CBC, direct Coombs test. We send the immunoglobulin levels, IgG, A, M, E. We send the lymphocyte subset, and we send the vitamin B12. If we have the facility, we can send apoptosis assays and double negative T cells, and we can go for whole exome sequencing as per the or targeted inborn errors of immunity panel if the phenotype is very classical, and we can diagnose the patients. So the treatment for these patients who have underlying inborn errors of immunity first remains the same, corticosteroids and IVIG for ITP. Then we have the second line agents, rituximab, mycophenolate mofetil, sirolimus, and eltrombopag for refractory ITPs. Then comes the targeted therapy. Like in this patient, the patient has a STAT gain of function mutation, so we started him on tofacitinib. If a patient had similar ctLA4, LRBA, and if the patient is affordable, we can go for abatacept and APDS, leniolisib, but it is not available in India currently. So that was autoimmune cytopenias. Now coming to the second presentation, which a hematologist can face, is lymphoproliferation. It can be the first sign for underlying inborn errors of immunity. So it can present with lymphadenopathy, hepatosplenomegaly, tissue infiltration in lungs, GI or CNS, and lymphocytosis in CBC. So if in a hematology clinic, we see a combination of unexplained chronic lymphoproliferation, cytopenias, we should work up the patient for inborn errors of immunity rather than going for a lymph node biopsy for such patients. So the underlying disorders which can present with non-infectious lymphoproliferative disorders are many, and most of these disorders come to the category 4. That is the immune dysregulation category. They can have concomitant enteropathies, they can have endocrinopathies, eczema, granulomatous disease, neurologic involvement, and family history, and hypergamma or hypogammaglobulinemia. So we should evaluate the patient for all such disorders as a multidisciplinary approach, along with the gastroenterologist, endocrinologist, and a pulmonologist. So the approach almost for this underlying inborn errors of immunity remains almost the same. But one thing is important is that we should send the EBV load for these patients, and we should always rule out a clonal lymphoma. But in inborn errors of immunity, clonality may emerge from a polyclonal background. So it becomes very important whether this lymphoproliferation is clonal or polyclonal. I will explain that in the subsequent slides. So coming to the third most important feature is malignancy. It is the second leading cause of death in patients with inborn errors of immunity. So coming to a case again, we had this patient who was 26-year-old male diagnosed with Hodgkin's lymphoma, presented with HLH, and prior to that, he had a history of waxing and waning lymphadenopathy. He was treated with dexamethasone and IVIG, followed by ABVD. Because of the HLH and previous history of waxing and waning lymphadenopathy, a suspicion of inborn errors of immunity was done. And findings related to the phenotype, MAGP1 gene was detected, and then it was likely pathogenic, and it was associated with EBV infection as detected on whole exome sequencing. So it becomes very important to take a good history so that we can know these patients who present with lymphoma with underlying inborn errors of immunity. So it is, as I told you, second leading cause of death. Over the lifetime for these patients, 4 to 25%, they carry a lifetime cancer risk. Non-Hodgkin's lymphoma is the most frequent, and EBV drives a major fraction for these inborn errors of immunity associated lymphomas. So cancer surveillance is part of long-term inborn errors of immunity care. So when a malignancy should trigger an inborn errors of immunity evaluation, rare atypical histology, early age at onset, virus-specific tumors, and treatment-related complications. Like on receiving a standard therapy, patient has severe toxicity, or has poor count recovery, or has recurrent or infections, then we should consider as patient can have an inborn errors of immunity underlying. So this is a chart which shows that a patient with a malignancy, like lymphoma, NHL, has infections, very severe infections, we should think of SCID, common immunodeficiencies. Patient with T lymphoma, B lymphoma has increased toxicity. We should think into the DNA repair defects and radiation sensitivity. If a patient with lymphoma has autoimmune lymphoproliferative symptoms, we should think of primary immune dysregulated disorders like CTLA4, ALPS. We should think of that. And if the patient has a myeloid malignancy and also has pancytopenia, we should think about stem cell bone marrow failure syndromes, and we should work up the patient accordingly. So coming to a very important aspect, that if a patient of inborn errors of immunity has lymphadenopathy, so how to differentiate whether and or lymphoma? It is sometimes very difficult because they can coexist together. In the histology, there is it is easier because it is reactive follicular and paracortical expansion can be seen. In lymphoma, that's why we need a excisional biopsy so that the architecture can be assessed. PET-CT is not a very good tool to differentiate between polyclonal lymphoproliferative disorder or lymphoma. A good response to immunosuppressive therapy like rituximab, sirolimus, abatacept, on giving these drugs, if the lymph node had decreased in size earlier, then it is an indirect evidence, then the patient might have had a polyclonal lymphoproliferation. A waxing waning coat supports polyclonal, and EBV drives both the polyclonal as well as lymphoma. If a patient of inborn errors of immunity has a very chronic lymphoma and has recently changed into a lymphoma, like having these symptoms, then rebiopsy and clonality testing are often the deciding step. So the workup almost is the same, like immunoglobulin levels, lymphocyte subset analysis, double negative T cells. Along with that, we should send the EBV, HHV8, and as per the malignancy, we can go for telomere length and stress cytogenetics. Coming to the fourth aspect that a hematologist faces is bone marrow failure syndromes, or MDS. This is the most easily recognizable to a hematologist, and they are mostly well versed in managing these patients. The various disorders are Fanconi anemia, DKC, GATA2, SAMD9L, DADA2, ADA2, ERCC6L2, or MECOM. And this MECOM presents with skeletal anomalies, hearing loss. ERCC6L2 presents with microcephaly, developmental delay. And DADA2 presents with stroke, autoimmune manifestations. It's usually present with autoimmune manifestations. And SAMD9L presents with Mirage syndrome, ataxia. It is called as ataxia pancytopenia syndrome. So we should get a bone marrow for these patients, send a karyotype, at a stress cytogenetics, telomere length as per the phenotype, go for DADA2 enzyme activity, monocyte count, human papillomavirus, mycobacterial workup as needed. Coming to the fifth aspect, which is HLH and HLH mimics. It is a very interesting aspect. I will start it with a case. We had recently a 1 year, 10-month-old female presenting to us with pancytopenia and acute liver failure. We diagnosed her with HLH using the HLH criteria. Pending the NGS results, we started the patient on HLH94 protocol. Because we got the NGS report after 3 weeks, whole exome sequencing, we were seeing that the patient is not responding to the HLH94 protocols. And after getting this report, we shared the report with our immunologist. And there were 2 variants, NFKB1 and STAT1. According to his interpretation of these variants, NFKB1 did not look pathogenic, and STAT1 looked pathogenic to him after analysis. So he had planned STAT1 levels by flow, which was a functional testing for this mutation. But before we could get this functional testing, the patient succumbed to the illness. The learning from this case is that we should be very aggressive in seeing that HLH can also present with HLH mimics, and we should consult a immunologist early in the course of these disorders, because there are many targeted therapies which have come and which might help the patient immensely. 75% of patients of HLH presented with HLH before the inborn errors of immunity diagnosis was made. So coming to this very important aspect, which is HLH mimics. When HLH94 can be the wrong protocol for these patients, because these 3 group of patients can present with HLH-like symptoms, but they will not respond to the HLH protocols, which is the DEXA etoposide-based protocol. These are autoinflammatory disorders, the same spectrum of immune dysregulation, STAT3, CTLA4, LRBA, and vasculopathy like GATA2 and DADA2. And the most relevant classical examples of HLH which have inborn errors of immunity, they can be classified into 2 types, primary HLH and other immune dysregulation disorders associated with HLH. So in primary HLH, we can present without hypopigmentation or with hypopigmentation. Without hypopigmentation, you must have come across perforin deficiency, Jung13 deficiencies, syntaxin 11, and with hypopigmentation, they are classically recognized on just seeing the patient. Griscelli syndrome, Chediak-Higashi, Hermansky-Pudlak, and other immune dysregulation disorders which can present are XLP1, TIN3, and CD27, CD137. So for the HLH approach, We have to send the ferritin, soluble interleukin 2 receptor if available, which is not available at most centers. We have to send triglyceride, fibrinogen, nanomorphology. We should consider to get a NK cell function granule release. Perforin or granzyme expression by flow should be done. Awaiting, because the NGS reports take quite a few time to get reported. Then we should go for these tests to try to establish confirm the diagnosis for these patients. EBV viral load we should send. Coming to the last aspect that the hematologist encounters commonly in his practice is eosinophilia. Persistent unexplained eosinophilia, especially with severe skin or skeletal feature, should raise suspicion for an inborn errors of immunity. Like patients who have IgE levels more than 2000, they give history of skin and sinopulmonary infections, have skeletal or dental abnormalities, which points us towards eosinophilic syndrome, HIES related disorders. So the most frequent inborn errors of immunity which present with peripheral eosinophilia are STAT3 eosinophilic syndromes, which can present with tooth retention, high palate, skin abscesses, fungal infections. Dockate, we can see, they also present with skin abscesses, allergies, fungal infections. IPEX syndrome is there. Then we have STAT3 gain of function, STAT1 gain of function, which can present with multi-organ autoimmunity, like endocrinopathy, arthritis, CTLA4. They can present with enteropathy and lung involvement as well. Other disorders, viscotalric, can also have associated eosinophilia. Omen syndrome presents with very early onset life-threatening infections. So the approach remains the same. We have to send immunoglobulin levels, lymphocyte subset analysis, because the patient has eosinophilia. So we should always exclude parasites. Send if the phenotype matches, we can send STAT3 functional assays upfront also. So how does the testing strategy works for these patients? As I've already told you, with all the different manifestations that we should send the CBC differential, immunoglobulin levels, lymphocyte subset, double negative T cells. Among the tier 3 and tier 4, as a hematologist in the OPD, because these tests are mostly done by an immunologist, we end up sending the targeted inborn errors of immunity panel or the whole exome sequencing before this functional assays. So this is one thing that we should always discuss with the immunologist. Subsequently, the patient should be seen by both the departments simultaneously, so that we are not missing something. So coming to this, trying to explain with this figure, that when we send this basic diagnostic evaluation and immunophenotyping, which we can get T lymphocyte subset, and because functional testing may or might not be available at your center with a limited number of functional testing. So when we have the genomic analysis, and if moreover, if it is a VOS, variant of uncertain significance, so it requires us to go back to the immunophenotyping, order the functional tests, and order for maybe, again evaluate the patient, take a history again, and also include a medical geneticist if needed, because for segregation analysis. So it is not like a continuous tired approach. We have to go back and forth with the genetic result. Then we might need a functional testing again. So coming to this case 4, this was a 41-year-old female with cytopenias, splenomegaly, and chronic diarrhea. So many workup had been done, many lymph node biopsies were done, but it was not contributory. So whole exome sequencing, PID panel was sent for this patient. So we got a CTLA4 variant mutation in this, but it was a variant of uncertain significance. As we see that the VUS is a very frequent classification we see in our NGS reports. So I thought I should try to explain how we can approach a VUS in a clinical practice. So the best thing is to consult an immunologist, because they know about these patients more than us. So it is important to consult them. Then we should, in consultation with immunologists, we should try to send a well-established functional study to confirm the pathogenesis, which I will talk which all functional studies are available in India in the next slides. We should go for parental testing. For the ctLA4, we can go for the targeted sequencing of the parents for this particular mutation. Or we can use the Franklin Genox online tool, which was told to me by the immunologist at our center. So the next slide will be a 2-minute video. How to use this. So coming to the well-established functional studies that are present in India, it is, I think, I have taken this, I've made this slide from the information available on the National Institutes of Immunohematology, which is in Mumbai. It is a specific center which which is labeled as National Institute of Research on Blood and Immune Disorders, which is under the ICMR. So many functional studies are are available at this center. So naming a few, like evaluation of intracellular surface protein expressions, which is BTK for X-linked A-gamma globulinemia. For viscotaldric, we have the VASP gene, VASP mutation, VASP protein mutation. For perforin is there for HLH. For ctLA4, like in a patient, we can evaluate for surface protein expression for these patients to confirm the pathogenesis. By flow cytometry, we have many tests, like in chronic granulomatous disease, we have DHR, CD11, CD18 can be assessed for LAD, and many more. And many other specialized tests were also mentioned on the site, and we can send the samples there in coordination with the doctors there. They are the specific antibody response. They are the ADA2 enzyme activity for DADA2 and ADA-SCID. IgG subclasses can be seen. We can send the complements, PEC for newborn screening, and TCR-V beta proliferation. So I came across this very interesting article, which was titled as "VUS No More: Decoding Inborn Errors of Immunity for Clinical Action," because PI3K APDS syndrome did not have any functional testing as such. So it was labeled under complex functional testing. And in this study, they confirmed a patient of VUS as pathogenic, and they could predict response to leniolisib, which is the targeted therapy for this disorder. So it is very important. It is an active area of active research priority that we have equivalent functional assays for other inborn errors of immunity genes, especially important for patients who have in their NGS report, VUS is reported, because without proving the pathogenesis, it is very difficult to plan targeted therapy. So when to send a targeted panel versus whole exome sequencing and whole genome sequencing. So targeted panel is sent when we are clear about the phenotype. It is a monogenic suspicion, and in the targeted panel, there is a curated gene panel and selected non-coding regions. The reporting is faster. The cost is a little higher than the whole exome sequencing as of now. And whole exome sequencing, we can send, it only sequences the protein coding regions. It should be sent if there is an ambiguous phenotype and the targeted panel was negative, even if it was not negative, and if we on clinical suspicion feel that it is an ambiguous phenotype, then we should send this. CNV detection rate is low. And coming to the whole genome sequencing, it sequences both the coding and the non-coding regions. It should be sent when there is whole exome sequencing is negative and non-coding region mutation is suspected. So these are the few variants where the variant is present on the non-coding region. So there are many disorders which can be expressed even by the non-coding region. So coming to the therapy decisions, we should plan therapy as supportive care, mechanism directed, or definitive therapy like transplant. Supportive care encompasses hypogammaglobulinemia, vaccinations, antimicrobial prophylaxis, and surveillance. Surveillance is important to watch for any new onset of cancer, autoimmunity, and organ damage. Immunoglobulin replacement is done when the indications are listed below. We can go from 0.4 to 0.6. We can go for subcutaneous. And the targets is that we should maintain the IgG levels more than 500 to 700 and monitor the IgG infections, and lifelong is planned unless reversible cause is there. We should plan the vaccinations. We go for inactivated vaccines, avoid live attenuated. We can go for vaccine response testing. We should also vaccinate the household contacts and go for inactivated annual influenza vaccinations. Antimicrobial prophylaxis can be individualized on the basis of the kind of defect that is there with the underlying defect. Coming to the targeted therapies, we have jakinibs, which is tofacitinib, ruxolitinib, which is available for STAT1, STAT3. Upadacitinib is more selective and is mostly used by immunologists nowadays. And we have abatacept, CTLA4, which is used for CTLA4 LRBA. Abatacept is currently not available through government scheme, but it can be used as a bridge to transplant to reduce PID-associated complications. For PI3K delta syndrome, leniolisib is there, but it is not currently available in India. HSCT, coming to the last part of the presentation, how to plan for hematopoietic stem cell transplant and gene therapy, if available in your country. So when is hematopoietic stem cell transplant the right answer? These set of disorders, they present with, should be exclusively treated by hematopoietic stem cell transplant, like SCID, Viscot-Aldrich, mostly HSCT for CGD, GATA2. And in this category, we have the in-between category where the LRBA, CTLA4, STAT1, STAT3 are mentioned. And on the left, we have disorders which have to be managed exclusively by medical or mostly by medical means. So in between lifelong immunosuppression versus hematopoietic stem cell transplantation, as after discussion with the immunologist, I came to this conclusion that lifelong targeted therapy can be planned for STAT1 and STAT3 because it is cheaper, and hematopoietic stem cell transplant might be a good for these kind of deficiencies like LRBA, CTLA4, because abatacept might not be affordable for longer durations and might be best used as a bridging therapy before only. And PI3K delta, I think we should go for transplant at this time till the time leniolisib is not available. And both the immunologist and hematologist should take part in the decision-making process. So this is the flow chart. When we know the genetic diagnosis and the patient is referred for allogenic stem cell transplant, we start with a family history of PID. If the mutation is present, then mutation should be identified via family screening. We should look at the clinical phenotype. If it is severe, non-severe, life-limiting, Then if the disease specific drugs are available, then we should go for that. If disease specific are not available and there is a good evidence that there is that allogenic stem cell transplant should be planned, if it is no, the evidence is not good, then we should go for disease specific drugs only. And if it is a maybe is for those disorders where the data is present on less than 10 cases. So if it is maybe and the patient is fit, we should go for transplant as a pilot or a clinical trial. And if the patient has good evidence, evidence for that disorder is good, and the patient is fit, we should go for transplant. And if the patient has a VUS, and then we should go for functional studies to confirm the pathogenesis. And then if it is no, functional studies are not showing the pathogenesis, then we should continual review for etiology. So just a few last slides on how we should go for conditioning intensity in inborn errors of immunity. It was a very important paper published in 2021, which clearly mentioned how do we plan therapy, and it was in the form of protocol A to F. A, B being the most myeloablative, and C, D being reduced toxicity. E might lead to more mixed chimerism, fludarabine and melphalan, and F is for to avoid organ toxicity. It is only recommended for DNA repair radiosensitive disorders in which alkylating agents are used in low dose. So donor selection requires very careful selection because we should screen the donors for these mutations, and because they can be silent carriers as well. So coming to the last slide, which is like if gene therapy is available in the country, then we should go in these particular disorders where it is approved, like ADS-SCID and X-SCID. We should go for this. And there are currently trials going on for viscotalric and X-linked chronic granulomatous disease and Fanconi anemia. And the trajectory is rapid, and what is investigational today may be standard within 5 years. So we should be updated on these gene therapy results. So the concluding slide is that for the hematologist, we have to recognize these disorders in our current practice. We should investigate them by doing CBC, immunoglobulin levels, going for a targeted or whole exome sequencing panel, sending functional assays, which well-established functional assays which are available in our country, and also have international and national people whom we can send these complex functional assays as well, treat by discussions with immunologists and many other departments, and transplant and gene therapy when indicated. I acknowledge the patients' families and my department and the resources that I've used to build this talk. So thank you. I finished my slides.
Thank you, Dr. Mona, for that very exhaustive subject you covered so beautifully and made it so simplistic. I think many of us have absorbed what you said. So we will have some questions. Some questions have come in the chat box. Some questions have been received by email. One interesting question is that how do you decide between the indication for transplant versus lifelong conservative treatment like replacing immunoglobulins or keep giving immunosuppressive drugs?
So there is because for X-linked gamma-globulinemia and many other diseases, because in our center, but I'm talking about my center, how we take decisions, because immunoglobulins are provided through the government rare disease funding, sir. So because it is available so freely and crores of immunoglobulins are available for patients to take. So if the center is well equipped to give lifelong immunoglobulins, we should go for that. And like in because I'm coming to abatacept, sir, CTLA-4 and is the drug of choice is abatacept, but it is not currently available freely. We are using for transplant patients, but lifelong cost will be too exorbitant for the patient. So according to what the patient can afford, and then we have to take this decision, sir.
Thank you so much. That was quite a perfect answer. One question, what are the exact indications for using JAK2 inhibitors? So
JAK2 inhibitors are used in two conditions, STAT1 gain of function and STAT3 gain of function, sir, specifically. And the patient that I have experienced had STAT3 gain of function, sir, and it was magical for that patient. So he responded all the autoimmune cytopenias recovered, and he's doing well, sir.
Right. How do you manage low-grade systemic inflammation in patients with IEI?
So low-grade systemic inflammation, sir, I think it will be covered by immunology, sir, because we send those patients because they give pulse steroids. This is what I have noticed, sir, but I don't know.
Right. Patients who have waxing and waning lymphadenopathy, how do you decide when to do the biopsy for excluding lymphoma?
Sir, because it is very, very difficult clinically when to go for biopsy, because PET CT does not really help because the uptake is there in both. So, sir, going for biopsy and being very particular that we have to send for clonality studies, sir. Being very clear that what we need from the biopsy, going for an excisional biopsy, and then going for clonality studies should be the answer. Maybe we have to do 2-3 biopsies if the suspicion is very high, sir.
Right. Another question is, since the patients in India present very late to hematologist after visiting large number of physicians. Sorry, it has moved. Could you please tell us the indications to do the screening for IEI in a general medical OPD?
Sir, the indications, because in the last years, what I have noticed in my practice is that because in 2021, the cost of, sir, targeted panels was 20 to 25,000, sir. Now the cost has decreased to almost 8,000 for whole exome sequencing, and targeted is still 12 to 15,000. So the cost, sir, we have to recognize, because the unrecognized disorders are many, sir. In general medicine practice, I think the combination of autoimmune cytopenias, any lymphadenopathy, which is waxing waning, and any unusual infections, any prolonged side effects of chemotherapy, or I think that should be a good trigger, because and the patient can afford also, sir, now NGS.
Sure. Do you routinely use H-score and T-cell activation by flow cytometry to diagnose HLH in adults?
Sir, H-score is, I think, specific for adults only. So we use it very regularly. And sir, the next thing was, sir?
T-cell activation by flow cytometry.
So T-cell activation, so I don't think so we are doing, sir. We are doing, sir, perforin evaluation, sir, for genetic disorders, but not otherwise, sir.
Right. Many adult cases of HLH are being recognized increasingly. Your experience with NGS in such patients and the management of HLH secondary to infections like EBV, enteric fever, scrub typhus, etc.
Sir, adult patients, sir, recently we had collected, sir, 100 patient data. Sir, in adult patients, over past 5 years in SGPGI, so there was hardly any, in adults, hardly any inborn errors of immunity we saw, sir. All were secondary to dengue, hepatitis A, E, all were seasonal illnesses. And the treatment, which was because they presented to SGPGI late, so the treatment they got was a short term of dexamethasone and IVIG, sir, till the inflammation subsided, and then uh, it was not chemotherapy based. And for EBV, sir, specifically, it is a strong trigger to send, sir, inborn errors of immunity.
Vibha has put up a question. Whether we should advise transplant for a 1-year-old baby who has ALPS driven by fast gene defect. Also, this has been reported as VUS. So how to proceed further?
Sir, this problem of VUS, I will call it a problem only, sir. VUS is not confirmatory. We cannot decide on VUS for a transplant, at least. We have to go for lymphocyte subset analysis. For ALPS, sir, it is a very nicely placed uh, uh, how to diagnose VUS. There is a guidelines. So we should just stick to that, get a lymphocyte subset analysis when the patient is not on prednisolone. This is very important because it changes the lymphocyte subset.
Right. Another question is, about hematopoietic stem cell transplant in these patients, what factors to use in deciding the conditioning, especially in SCID, and how or can we move without conditioning?
So for SCID, because sir, I'm not an expert in doing these transplants, so I will not take that question, sir.
Fair enough. Dr. Shweta, you have some question?
Good evening, sir. Thank you. It was such a nice presentation, and being pediatric hematologist, it's very important for us to understand the topic well. Actually, no, I mean, I don't have questions. Some comment I want to make and want some guidance from you, sir, and the madam also. I have done a small study on 20 pediatric patients, all less than 12 years, who presented to me with chronic ITP. I mean, initially, they were all fitting into the diagnosis of ITP, as in no other cytopenias, ANA was negative, and the bone marrow was normal. Peripheral smear did not show anything abnormal. So, but eventually, when they become refractory after 1 year, I mean, with some funding, I tried to do exome sequencing only in 12 kids out of 20. And I've selected only those who are actually refractory to more than 2 lines of therapy. So out of those 12, almost 5 I found some of the other abnormality. One was the RAG mutation, then ZNFX mutation, TNF mutation, ATM mutation. So all these mutation I found, and then on retrospective analysis, I found that there was some abnormality in the marrow in the form of some macro thrombocytes, and even some of 2 patients we did parental screening also. They were all heterozygous and carrier of the same mutation. So now I've counseled the parents about bone marrow transplant, because they have refractory thrombocytopenia, which is not responding to the therapy, especially the one who had recurrent infection also in last 1 year. So I mean, actually, I'm working in a government hospital. Funds are limited, so I cannot do transplant of even when it is indicated. We are unable to do. So I mean, there should be some. I mean, what do you say in this, sir? I mean, we make some kind of guidelines that after certain period, especially in pediatric patient, after listening to madam's talk, should we make a kind of guideline that after certain period of time, especially in pediatric patient where the immune deficiency disorder, immune dysregulation disorder are so common, it should be mandatory to do genetic testing, because there's nothing written. I mean, there's no such guideline. I went through many articles, but I didn't find any kind of particular guideline that at this point of time the genetic testing should be considered. So what is your thought in that, sir?
Dr. Mona?
Actually, the traditional teaching for ITP specifically, because you're asking, that 80% of patients of ITP do very, very well, actually. They don't need any testing. So it is just a clinical, because the patient who continues to be refractory ITP, if we are seeing more of them, then maybe, it is a referral bias. But 20%, as per the literature, they say we can go for testing. But it has to be a chronic refractory ITP, like your patients. You selected a very good subset. So that's why I think you are finding those results. So maybe common, everybody, I don't think so, but it is like chronic refractory is a good, I think underlying, he can be suspected for an inborn errors of immunity.
Yeah, and I think it's more in pediatric patient. I mean, my subset is all patients are under the age of 12 years.
Yes.
So I think this is more common in pediatric patient as compared to adult.
Yes, definitely. You're absolutely right. It is mostly seen in these patients.
Okay, and one more question I have, sir, if I can ask that question, sir. Sir, that I have a girl, 12-year-old girl with B cell ALL. So that girl, I mean, molecular was normal, karyotype normal, CD20, I mean, typical B cell ALL with this thing, continuous infection, recurrent infection she has. So, I mean, my question is that, I mean, despite induction, I mean, it's been 2 months since we are still struggling with completion of induction. We still have not completed. So, I mean, because you said there are some association with malignancy also. So, when do we consider doing the NGS testing in such cases where you're struggling with the chemotherapy or unable to do that? There are frequent infection, and in a typical case of B cell ALL. What is the point of considering the testing?
Actually, BLL is not a very common association with inborn errors of immunity. It is mostly AML, MDS, but many things are unknown. I think sending a whole exome sequencing from peripheral blood should not mean that we should have a very low threshold to do these tests, because they can be, properly guide our, patients. Because the next chemotherapy, if the patient recovers from this one, the next we have to decide on the dose for that one also. So it is better to send. We might find new things.
Okay. Thank you. And one more question. What is the ideal sample? So, I'm sorry. The sample for, because they are getting repeated transfusion. So swab or peripheral blood?
I think
5 ml peripheral blood.
I think they will go for a swab, I think, because
Swab
with
only.
distant blood, yes. Because the 70% success rate they say, but we can't do anything.
Okay. Yeah. Thank you. Thank you. Thank you.
Thank you. Dr. Sohini.
Good evening, sir. Great talk, Dr. Mona. I have one just question that, like certain places like HLH or even like GATA2, we have got guidelines that even if you've picked up a mutation while screening a donor, you will actually advise the family to think about transplanting if there's a pathogenic mutation picked up even before the symptoms have started. Right? But what happens, because we've had patients when we have screened the donor was fine, and eventually a year or two comes with frank HLH and the mortality really goes up. So in those scenarios, we do advise transplants, even when you picked up a perforated mutation. But what about the new mutations like ctLA4? Is there a data about that?
Ma'am, I'm not quite sure that ctLA4, it usually presents with the HLH mimics, ma'am. What I could learn, that, we have to go for targeted therapy and not for transplant, ma'am. It is an in-between category. ctLA4, these immune dysregulation disorders, they are not clear-cut indications for transplant right now.
No, but if the patient has come, I'm not talking about the patient. Now you've had a patient
the
who's had
donor,
a ctLA4, has exactly.
No,
You're
ma'am, for the
screening the whole
donor as well,
family.
ma'am. No, ma'am,
You're
the
screening
donor.
the family and you've picked it up and your patient is asymptomatic. What would be your take on that?
I think we have to watch the patient closely. We have to, for whatever symptoms, enteropathy, like the lung involvements. If the patient starts having symptoms, I think immunologist is a better person to decide. We can all come together and, decide the therapy when the symptoms start, ma'am, I think, not before that.
Sure. Thanks.
Any more questions? One more question in the chat box is about splenectomy for refractory ITP in a person who has immunodeficiency disorder.
Sir, I think it is mentioned as third-line treatment also in the guidelines for inborn errors of immunity patients, but it is I think the last resort for these patients.
Dr. Mona, sir, good evening, sir. Can I ask some question?
Please go.
Dr. Mona, I want to know about gene therapy, how frequently, how we do it.
Sir, my experience of gene therapy was when I went for my observership in London, sir, because when they were having their multidisciplinary team rounds, they used to have, patients of Viscott Aldrich when they were planning whether they should send for allogenic transplant or gene therapy. So I think in India currently we don't have we don't have access to gene therapy. But if the patient is from such country or can go to such countries to get the gene therapy, then it is a valid discussion for patients of SCID, Viscott Aldrich, to either opt for gene therapy or go for transplant as per the availability, sir.
Yes.
And affordability. Yes.
In India, we don't do now.
No, sir. Not currently, sir. We don't have.
Thank you.
I can just make a general statement that gene therapy, the adverse effect profile is so much better than allotransplant that as and when it becomes easily available, it will be a big challenge to allotransplants. It's happening in the field of thalassemia worldwide, and it will happen probably to all the diseases once the safety of gene therapy, wide availability, and the cost factor are taken care of. The results look very, very impressive as against allotransplant, which is standard of care in India.
Yes, sir.
Dr. Vibha.
Sir, just addendum to the question I had asked in the chat box. So this 1-year-old child, I mean, I was wondering what will be the study for that fast defect, sorry. What will be the functional study for that? So
No,
I've
fast-
already done the subset, and he has a very high 35% of double negative cells. So is that good enough to diagnose? Because we need to counsel the parents and label the child.
Ma'am, actually, there is a apoptosis assay which is mentioned, which can be, I think, you can coordinate with the National Institute of Immunohematology. Maybe they can guide you to send samples. Yes, ma'am.
Okay. And the last thing, do we advise transplant for such a child?
Ma'am, for an ALPS patient, ma'am, the literature that I studied for ALPS specifically was only 3% of patients needs transplant. They can be sometimes, but
yeah, he's
then
doing
the
very
patient-
well on sirolimus. I've already started him on sirolimus,
Yes,
and
I
he's
think
quite good.
it's yes,
Thank-
ma'am. It should be good.
Okay.
Thank you,
Okay.
Dr.
Thank
Mona.
you.
That's all the
Thank you.
time we have.
Thank you.
Thank
Thank
you.
you.
Thank you for delivering this lecture, and thanks to all the participants for very, very active discussion. It was very enjoyable. This is a unique subject, and I think a lot of learning. So thank you so much, Dr. Mona.
Thanks.
We'll move on to the second web lecture. Our guest speaker has already logged in. I'll just share my screen to introduce our guest speaker. So we have Dr. Jardine Fabris from France. He's professor, Department of Clinical Hematology at Henri Becquerel Cancer Center in France. He heads a research team dedicated to lymphoma genomics. He's also the principal investigator in several multi-center clinical trials in diffuse large cell lymphoma, particularly in elderly subjects. He's a member of the LISA Scientific Advisory Board and the French Society of Hematology. Today, he's going to lecture us on ctDNA and lymphomas, a very, very interesting subject, which is probably changing the whole outlook of approach to patients of lymphoma. So over to Sir. I'll just stop sharing. Yeah. Yes, Dr. Jack.
Thank you, Dr. Agarwal, for your kind invitation. This is a second one, I think. So I will discuss today regarding ctDNA in lymphoma, and I will share my slide if I can. Let me know if you can see.
We can see your screen now. Yeah.
Is it okay for you?
Yes, perfect.
Okay, so thank you. So we are discussing ctDNA in lymphoma, and I will focus my my talk mainly in diffuse large B-cell lymphoma, in Hodgkin lymphoma, because I think that ctDNA is a tool that is more interesting in this setting of diffuse large B-cell lymphoma or Hodgkin lymphoma. For me, ctDNA is a molecular Swiss knife in lymphoma, because ctDNA gives you information regarding tumor volume, minimal residual disease, give you also information regarding genotype, of course, but also many other information such as epigenetics. ctDNA is part of the concept of liquid biopsy. As you know, you can catch many information regarding tumors in the blood of your patient. You can catch, of course, tumor DNA, ctDNA, but also exosome, CTC, circulating tumor cells, and many other information that are kept together in the concept of liquid biopsy. For ctDNA, it's very simple to get the source of cell-free DNA, because it's blood, it's mainly plasma. We know that plasma is better than serum. So you can collect from your patient between 10 milliliters to 4 milliliters plasma. You have to take care that centrifugation is performed very quickly, less than 3 hours after the blood collection, and then you can perform storage just after. You can use sometimes some specific tubes, such as cell stabilizing tube, to avoid white blood cell lysis. And after this pre-analytic procedure, that is very important to obtain good quality of DNA, you can perform analysis in the goal to genotype your tumor or MRD. What we know about ctDNA, you have to differentiate ctDNA and cell-free DNA. Cell-free DNA is arise from apoptosis of nucleated cells and mainly hematopoiesis cells in steady state. And this cell-free DNA is present all the time with some variation during the day. For example, we know that there is variation during the day with a peak during night, for example, and there is also variation in healthy subject. But in any case, the concentration of cell-free DNA is quite low. You have to differentiate cell-free DNA from ctDNA that is only a fraction of the cell-free DNA. This fraction is variable according to the type of cancer or tumor you analyze, ranging from 0.01% to 90% in some situation of tumor, solid tumor, for example. As I told you, plasma is better to get cell-free or ctDNA than a serum, and we use now a plasma. We know also that the DNA size of ctDNA is lower than cell-free DNA. Other information that you have to keep in mind when you analyze ctDNA is that the main source of ctDNA is apoptosis of tumor cells, and the size of the ctDNA fragment is around 166 base pair. We know that there is also other sources of ctDNA, including necrosis, active secretion of complex protein that contain lipids, proteins, and DNA, but also in some situations, some circulating tumor cells that provide also ctDNA in this context. The most important thing that you have to keep in mind is that the half-life of ctDNA is 2 hours. I think it's the main information of this slide, and if you retain only one thing, retain this thing, the half-life of ctDNA is 2 hours. It means that if you detect ctDNA in your patient, you know that the tumor is present and is active. So this is why this is the most important information of this slide. There is some differences between tumors, and the release of ctDNA is depending on the type of tumor and the type of lymphoma. For example, you know that Steinberg cells are very rare in the tumor, but in fact, the release of ctDNA is very high in this kind of cells. And we don't know exactly why, but maybe because it's related to the microenvironment of the tumor, and especially the activity of a DNase 1L3 that his activity is correlated with the release of ctDNA in this tumor. But there are many things that we don't know, why some lymphoma release many amount of ctDNA and why other lymphoma have not this feature. So by you analyzing ctDNA, you can have some information regarding mutation, of course, genotype, but also copy number alteration. In some situation, you can detect gene fusion. It's not a feature that you can have in lymphoma, mainly in acute leukemia, but not in lymphoma. And you can also have some information regarding methylation. We have many techniques. It's not the topics of my talk, but we know that we have many techniques to detect ctDNA with sensitivity, level of sensitivity very different. And for example, technique based on PCR, such as digital PCR, will show you some example after, or NGS based are very different, give you many different information with a level of sensitivity quite distinct between these techniques. So the goal of the ctDNA analysis is to catch in your cell-free DNA the mutation that are informative for your patient and for your tumor. So you start with an amount of DNA, cell-free DNA, and you have to detect the mutation, very interesting for your patient. If you can detect your mutation, you can, by this way, calculate the variant allele frequency that give you the frequency of the mutation in your patient and in your tumor. And you have many different techniques. For example, in this slide, I show you an example of digital PCR and the detection of a mutation of XPO1. That is a mutation that is mainly detected in primary mediastinal B-cell lymphoma or Hodgkin lymphoma. You can see the blue dots that represent the mutation of the patient in the tumors with a variant allele frequency of 22%, and the same mutation that you can detect it by digital PCR in this patient in the plasma with a variant allele frequency of 9%. You know that this mutation in lymphoma is mainly due to an activity of this enzyme, AID, that is responsible of hypersomatic mutation, giving you some mutation in VDG gene, but also in other genes that are targeted by this enzyme. By chance, in lymphoma, we have many mutations that are related to this activity of this enzyme. It's also true for T-cell lymphoma, giving you some tumor-specific mutations that you can detect by NGS in plasma of your patient. And the other feature of these mutations that are related to AID is the mutation that we call phase variant. Phase variant is mutations that are located in cis, in your DNA molecule, and are usually put together in a small region, less than 170 pair base. And if you have the chance to detect this variant phase, you are a very strong tool to use this mutation as MRD with a very high level of sensibility and sensitivity. And this phase variant are a feature of B-cell lymphoma, because you can see in this detection of phase variant, the tumors where you can detect the most frequently phase variant is follicular lymphoma and diffuse large B-cell lymphoma, but also Burkitt lymphoma. You can detect this phase variant in tumor solids, but this is clearly a feature of B-cell lymphoma. The genes that are targeted by phase variant is mainly immunoglobulin gene, of course, IgH, but also BCL6, BCL2, MYC, or ID3, for example, that are targeted by this phase variant. And this phase variant gives you a very robust target to analyze for the follow-up of your patient and the MRD detection. So as I told you, ctDNA is the perfect molecular Swiss knife for lymphoma. And the first point is that we know that ctDNA is clearly related to the tumor burden of your lymphoma and of your patient. We know that, for example, there is a strict correlation between the quantity of ctDNA that you detect at the time of diagnosis and some parameters that are related to the volume of the tumor. For example, there is a good correlation between LDH and ctDNA, good correlation between the metabolic volume estimated by PET scan and ctDNA. There is a clearly good correlation with the IPI score, as you can see in this slide, with a good correlation between the level of IPI and the quantity of ctDNA that you can detect at the time of diagnosis. Again, this data, this publication illustrates that the correlation between the volume of the tumor and the aggressivity of the tumor related to the IPI and the quantity of ctDNA. In our end, we also demonstrate that there is, of course, a correlation between ctDNA and metabolic volume, but there is also many correlations with other radiomics parameters, such as, for example, the dispersion of your tumor. The more you have tumor with dispersion, the more you have ctDNA in the blood of your patient. So there is many correlation with other parameters than metabolic volume that can explain the concentration of ctDNA at the time of diagnosis. Another point that we also demonstrated is that there is some differences between tumors and plasma. And these differences are related to the heterogeneity of the tumors that you can detect mainly in patients with a large metabolic volume. You can see here some PET scan data showing you different volume of the tumor, and we know that the differences between plasma and tumor genotype are related to the volume of the tumor, indicating that ctDNA integrate all the mutations that are detected in your patient, and not only the mutations that are present in biopsy. The second point, so as you can expect it, because ctDNA concentration is related to the tumor volume, there is also a correlation between the ctDNA concentration at the time of diagnosis and the prognosis. And this is a paper that published by Kurtz in 2018, showing that the concentration of ctDNA at time of diagnosis is clearly related to the prognosis of your patient. And it's partially independent of the tumor volume of this in this cohort. Again, another approach showing you this difference in a patient treated by CAR T cell. This is a concentration of ctDNA just before CAR T cell infusion, and you can see again that this concentration is predictive of the outcome in this patient treated by CAR T cell. The second point of the ctDNA, the most important, of course, is the role of ctDNA to detect MRD. And there is many data showing that this is now a crucial point. I show you just an example in my center of a patient treated at the time of diagnosis with this diffuse large B-cell lymphoma, stage 4, and after treatment, after 6 R-CHOP, you can see that this patient is in complete remission in this PET scan. And in the same time, we can see a decrease of the mutations that were present in the tumor and in the ctDNA of this patient. You can see patient were mutated for MYD88, for example, and this mutation decreased completely after 2 cycles of chemotherapy. This patient was a very early responder. So we know that now this is a crucial tool to detect MRD. Again, Elizabeth's team showed in this paper 10 years ago the role of ctDNA as a tool to detect MRD with many examples. And it also shows that there is two kinds of response. We can separate patients with early molecular response, meaning that you are decrease of 2 logs after one cycle of R-CHOP. And there is also major molecular response patients that are defined by a decrease of 2.5 log after 2 cycles of R-CHOP. So EMR and CMR, MMR patient defined by the decrease of ctDNA after R-CHOP. And you can see that patients that are early responder or major molecular responder are clearly related to a very good prognosis as compared to patients that did not obtain the molecular response. Interestingly, this is a tool that you can apply in many situations and whatever the treatment used. And this was demonstrated clearly in the POLARIX trial. You know well, I think, this trial comparing R-CHOP versus POLA-R-CHP. And you know that the main conclusion of this trial demonstrated that POLA-R-CHP is a better arm than R-CHOP, giving benefit in terms of PFS. And when we analyze in this trial ctDNA after one cycle of chemotherapy, whatever the arm, you can see that patients that obtain a complete remission after one cycle of chemotherapy were related to a very good prognosis as compared to patients that did not obtain the complete response after one cycle. So this is a very interesting tool because you can use it even if you change your standard arm, as it was done in this trial. If you applied the fast-seq sequencing, you remember that the mutations that are located in a small region of the DNA of less than 150 base pair, you increase clearly the sensitivity and the sensibility of your tool. And by this way, you are able to detect more patients that are high risk of relapse. And this was well illustrated by the last publication by again Kurtz and Elizabeth team. And again, you can see that using this fast-seq sequencing, you are more sensitive and you are more able to detect patients that will relapse, even if patients are negative by PET scan. So there is a clearly a complementary role of ctDNA as compared to PET scan in this setting, and this was also true after one cycle of chemotherapy. It means that you can now imagine to combine many factors in your patient to predict the outcome. You can combine IPI, PET imaging, cell of origin, GCB-ABC, and ctDNA based on the early molecular response or the major molecular response. And if you combine all these factors, you can build a dynamic predictive score as proposed by Kurtz based on this factor and adapt the treatment in your patient, tailor the treatment of your patient according to this factor. And this was done in this clinical trial. Maybe you were involved in this clinical trial by Roche that was based on ctDNA dynamics. So we start by R-CHOP, 2 cycles, and after 2 R-CHOP, we analyze ctDNA and the response after one cycle and tailor the treatment according to the response after one cycle. If the patient decrease the ctDNA of 2 logs, you keep on by R-CHOP. If the decrease is less than 2 logs, you change and add glofitamab, a bispecific antibody in this setting. So we are 40 patients were enrolled in this trial, and we are waiting for the result of this trial. But just to show you, to illustrate you that now you can tailor treatment according to response of your patient based on ctDNA analysis. And maybe ctDNA can be a surrogate of survival, because you can see in this data presented in the ASH meeting 3 years ago by Roszewski, showing that patients that are negative at the end of treatment are in blue, patients that are positive at the end of treatment are in red, and you can see there's a huge difference between these two category of patients, suggesting that ctDNA can be a surrogate of evaluation of new molecule in the setting of diffuse large B-cell lymphoma. Interestingly, cell-free DNA or ctDNA is also interesting in primary central nervous system lymphoma. We were, I think, the first to publish some data regarding this lymphoma subtype, and this was confirmed by again German study and a work that was performed by German and also Elizabeth's team, showing that you can detect cell-free DNA in primary system nervous lymphoma. You can also detect, of course, ctDNA in plasma, but also in CSF, with a concentration less than you can detect in nodal lymphoma, of course. Patients treated or not treated by corticosteroid did not change their concentration in this study, and there is a correlation between the volume of the tumor in CNS and the concentration of ctDNA. And interestingly, patients that harbor central nervous system lymphoma with periventricular involvement display higher concentration of ctDNA in this setting. Again, in this setting, ctDNA in plasma or in CSF is predictive of the outcome. The concentration, but also the MRD is predictive of the outcome in this setting. So it's very interesting tool, because you know that it's not so easy to perform biopsy in CNS lymphoma, especially in relapse. So I think ctDNA in CNS lymphoma is a very promising and very interesting tool. We also can imagine that you can combine both MRD response evaluated by ctDNA, but also the new classification of diffuse large B-cell lymphoma. In this publication, for example, they demonstrated that the BN2 or ST2 subtype are related to a good prognosis, but if you combine both this molecular classification and the MRD response, you can identify patients with a very good prognosis, patients with MRD negative and patients with BN2 or ST2 cluster are clearly related to more favorable outcomes that as compared to patients that are MRD positive or did not display BN2 or ST2 cluster. ctDNA is also very interesting in the setting of CAR T cell. As I show you, it's important in pre-CAR T cell, during the proceeding of the CAR T cell, but also in post-CAR T cell to detect MRD or occur mutation related to CAR T cell resistance or CAR T cell failure. In this publication, for example, it was shown that the detection of ctDNA at D7 after the infusion of CAR T cell was related to the outcome of this of diffuse large B-cell lymphoma. I will show you in some example in my that are I keep in my center how ctDNA was useful to make decision in some patients. Just show you an example of this woman that display a primary mediastinal B-cell lymphoma. You can see the PET scan at the baseline with a huge tumor of the mediastin in baseline. It was a woman, 37 years old. By chance, we were able to detect in the tumor, but also in the plasma of this patient, so many mutations that are typical of primary mediastinal B-cell lymphoma. And we detect XPO1 mutation. I show you before an example of this mutation. We detect this mutation, this hotspot, both in tumor with a variant allele frequency of 50%, but also in the cell-free DNA, you can see with a very high variant allele frequency level. These patients were treated by R-CHOP, and you can see a very good response, but PET scan is not completely negative. You can see there is some positivity in this area. It's very difficult to biopsy again, so we decide to treat by 2 additive R-CHOP, and you can see this PET scan after 4 R-CHOP. Again, there is something that remains, but it was very difficult to biopsy this patient. So we decide to analyze ctDNA, and by chance we detect again. This is the digital PCR at baseline. You see the green dots represent the mutation of this patient, and we detect mutation in the plasma of this patient at baseline. And after CAT for R-CHOP, you can see here dots, green dots again with a variant allele frequency of 1.6%. Here you can see green dots with the mutation. So we were completely sure that this patient had again active primary mediastinal B-cell lymphoma residual disease after 4 R-CHOP. And then we decide to treat this patient by CAR T-cell in second line because we think that this patient was refractory to R-CHOP. And now she with a follow-up of 3 years, we can say that she's cured. Another example of this patient with lymph nodes, you can see here. After 3 R-CHOP, these patients were considered in complete remission, but she relapsed after 6 R-CHOP. And again, this patient was MRD positive with detection of mutation of TP53, and we decide again to treat by CAR T cells, and this patient is now in complete remission. But we also perform biopsy in this patient because the biopsy was very easy in this setting, and there is a strict concordance between ctDNA and tumor DNA analysis in this setting. Another example, more complicated, with a patient that develop diffuse large B-cell lymphoma or mainly of the spleen, very, very huge lymphoma. We detect mutation of PCL2, cyclin D3, and TP53. This mutation were detected in the plasma of the patient at baseline, and we treated this patient with R-CHOP. We see that there is some remain glucose uptake in the spleen. After 4 R-CHOP, again, you can see that there is some remains in this imaging, and but in this setting, ctDNA was completely negative. We were not able to detect mutation in this patient, despite the fact that this CT scan, this PET scan was very, very positive with a Deauville score of 4 or 5. We are not sure. So in this setting, I have to confess that we decide to treat this patient with CAR T-cell, even if this ctDNA was completely negative, because this PET scan imaging was very suspect. we decide to treat this patient by CAR T-cell. And after CAR T-cell, you can see that there is some remaining uptake, even if this patient, we consider this patient in complete remission. So this is another case to illustrate you that sometimes it's not so easy to make a decision, and usually we combine both PET scan imaging and ctDNA to decide the strategy for your patient. We know that ctDNA is able to distinguish patient after CAR T-cell between progressors and durable responder at any time. If you collect your patient before CAR T-cell, at D1, at D5, at D14, or at D90, you are able to distinguish patients that are progressor compared to patients that are in durable response. So again, it's a very, very important tool in this setting of CAR T-cell. Again, in this trial, it was demonstrated that the concentration of the ctDNA just before CAR T-cell is a predictive tool of the outcome of your patient. Importantly, you can also detect some mutations that are maybe related to resistance to CAR T-cell. For example, in this publication, it was demonstrated that patients that are in failure after CAR T-cell develop some mutation targeting TP53, but also, as expected, CD19 or PAX5 as maybe marker of resistance in some situation after CAR T-cells. Again, Alizadeh team proposed a new tool of ctDNA analysis dedicated to patients treated by CAR T-cell. This tool gives you the opportunity to analyze both tumor genotyping, but also can quantify the ctDNA that are related to the CAR T-cell infusion. We know that there is also part of the CAR T-cell genome that are detectable in plasma of your patient after infusion of CAR T-cell. So they developed a very interesting tool that can give you information both in the tumor, but also in the microenvironment by T-cell analysis, and also give you information regarding the CAR T-cell itself. And they demonstrated again that the predictive value of ctDNA at 1 month after CAR T-cell, you can see that the patient with undetectable or detectable ctDNA at 1 month was clearly related to the outcome of the patient. But also, they also demonstrated that the quantity of ctDNA related to your CAR T-cell at week 1 was also predictive of the outcome. You can see here in this slide. So they developed a step score that is based on the addition of two ctDNA factors. The first one is the quantity of ctDNA that you detect at month 1, and the second one is cell-free DNA derived from CAR T-cell that you detect at week 1. So the combination of these two molecular factors define the step score and can define patient with a very good or very poor outcome. So I think this score is quite difficult to use in a daily practice, and only to my knowledge, only one team in the world use this, are able to detect, to use this tool. And I will finish now by the role of ctDNA in Hodgkin lymphoma. I think it's the setting where ctDNA is very, very interesting. The first point that you know, of course, that Ritzenberg cells is a very rare cells in the tumor biopsy. So it's very difficult to perform genotyping of Hodgkin lymphoma because of the rarity of the Ritzenberg cells. But by chance, We know, as I told you in the beginning of the talk, that the Ritz-Steinberg cells are able to release a large amount of ctDNA in the plasma of the patient, mainly based on the activity of DNAs that are secreted by microenvironment of the tumor. So by chance, we are able to catch many molecules of ctDNA in this setting. And it was clearly demonstrated 10 years ago by a Belgium team, demonstrated that you can detect hypodiploidy of the tumor in some patient in Hodgkin lymphoma. So we know that there is ctDNA that circulating ctDNA in the setting of Hodgkin lymphoma 10 years ago. And now, using ctDNA, we are able to propose new classification based on genotyping of ctDNA in Hodgkin lymphoma. We are not able to do that with tumors itself, but we are now able to propose new molecular classification based on ctDNA analysis. And again, Elizabeth's team proposed this classification H1, H1, H2, two subtypes, depending on the genotype. H1 is, for example, characterized by STAT6 mutation, B2 microglobulin mutation, and H2 is mainly characterized, for example, for TP53 mutation or BCL2 mutation. And interestingly, H1 and H2 are very different regarding the distribution of age, sex ratio, ABV status, but also finally outcome with the H2 related to less favorable outcomes than the H1 subgroup. So this illustrates you that genotyping by ctDNA is a very powerful tool to understand this disease. Another classification was proposed by German team. Heger proposed 2 years ago in this GCO publication, and identified 3 subtypes based again on the ctDNA analysis. The first one is based on inflammatory immune escape Hodgkin lymphoma, mainly characterized by PD-L1 and PD-L2 expression. And the second one is virally driven Hodgkin lymphoma based on the expression of EBV or HHV6. And the third one is oncogenic driven Hodgkin lymphoma, again based on some genotype based on ctDNA. As it was shown in diffuse large B-cell lymphoma, again, in Hodgkin lymphoma, MHG detected by ctDNA is also a powerful tool to predict outcome of the patient in combination with PET scan analysis. Another example, in our center, we are able to detect again this mutation of XPO1 in tumor, but also in plasma of the patient. And in a short cohort of patients, we are able to analyze this mutation by digital PCR, and you can see that patients that are still positive or increase the detection of the mutation by digital PCR during treatment were related to a poor outcome. And we recently published a work in Hodgkin lymphoma in children, adolescents, and young adults. It was a work that we performed with Hôpital Trousseau in Paris in collaboration, and we analyzed a panel of 18 genes that are frequently mutated in Hodgkin lymphoma. So it's a small panel that you can perform in many centers. For example, panels that include XPO1, but also SOX1, STAT6, beta-2 microglobulin, and other genes that are frequently mutated in lymphoma. And we analyze a prospective cohort of children and young patients that were treated according to an European protocol. And we were able to analyze 275 patients less than 25 years by this panel. And this work is recently published in Hemasphere. And the main finding of our work is that we were able to detect mutation in less than 90% of patients with this only panel, the short panel of 18 genes. We also demonstrated there is a clear relation between B symptoms and the quantity of ctDNA that you detect at the time of diagnosis, and some mutations were related to the outcome of our patient. Just to show you that there is, for example, correlation between sedimentation rate, the stage of the disease, and the concentration of ctDNA at the time of diagnosis. So there is a relationship between ctDNA concentration and marker of inflammation or bulky disease. For example, here you can see there is a correlation between CRP or hemoglobin and the concentration of ctDNA at the time of diagnosis. Regarding the genotype, you remember that it was only 18 genes that were analyzed in this trial, but the gene that is the most frequently mutated in our end was SOX1, that is mutated in most all the patients, so 70 or 80% of our patients. And the second one was beta-2 microglobulin. You can see STAT6, for example, is mutated in 35% of our patients. XPO1 is mutated in 15% of our patients. And we also identified some mutations that are exclusive between or some mutations that are present in co-alteration. For example, beta-2 microglobulin and XPO1 are frequently related. In terms of outcome regarding event-free survival, the concentration of mutation of ctDNA after 2 cycles of chemotherapy was clearly related to the outcome of this young patient. And when we combine both PET scan analysis and ctDNA analysis after 2 cycles of chemotherapy, again, we are able to identify patients with very poor outcome, combining inadequate response after chemotherapy and ctDNA detected after 2 cycles of chemotherapy. Interestingly, we identify mutation of XPO1 or IGLL5 are mutations that are not that are associated with a poor outcome. And in this setting, we define a group of patients that are not mutated for XPO1 or IGLL5 with a good response by CT PET scan, and identify 3 subtypes of patients with different outcomes. So to conclude, cell-free DNA quantification and genotyping are essential tools in lymphoma management. We can use digital PCR, but also targeted NGS based on CAPSEC or FastSeq analyses to quantify MRD. The dynamics of cell-free DNA after cycle 1 or cycle 2 in diffuse large B-cell lymphoma is independent factor related to progression-free survival and overall survival. For me, cell-free DNA and PET scan imaging are complementary in diffuse large B-cell lymphoma, but also in Hodgkin lymphoma and other histologies. And cell-free DNA provide baseline and dynamic genotyping in Hodgkin lymphoma, but also diffuse large B-cell lymphoma, but also in other subtype of lymphoma. But there is some remaining question. What is a more sensitive and specific method to detect ctDNA? What are the biological factors that contribute to cell-free release? Can we avoid tissue biopsy in the near future? Is there a clinical benefit to detect an early relapse by ctDNA analysis? What is the best timing for the ctDNA follow-up? And what are the respective role of ctDNA and imaging procedure and other prognostic factors? So I think this is a remaining question. And I will just thank the colleague with our work in Rouen, and that provides some data I show you in this talk. And now I'm happy to try to answer to your question.
Thank you so much, Dr. Jardine, for this. That was wonderful talk. You have given so much information to us. It was very, very educative. Phenomenal amount of work and the importance of this entity.
Okay.
I have a question. With such versatile test, what is preventing it from being used in clinical practice left and right? Why is it taking time to get into clinical practice all over?
Sorry, your question is what is the best technique to use in clinical practice, you mean? Or?
In a number of places, this still remains a research tool. It has not entered the clinical practice very widely.
Okay.
Why?
I think it's coming. You can compare the situation 5 years ago and now. Clearly, now there is many centers use ctDNA as a decision-making tool. For example, digital PCR it's inexpensive. It's very easy and of course, digital PCR you have to detect a targeted mutation, hotspot mutation. You cannot use a panel, but we use in daily practice. I think it's a question of time. Maybe you know that in acute leukemia world, you decide MRD. MRD it's a tool now to go to allograft or chemotherapy. I think in lymphoma, in 2 or 3 years, it will be also a very important tool to decide the strategy for your patient.
Right. Is it equally applicable to low-grade indolent lymphomas and T-cell lymphomas?
So, because of the time, I will not discuss low-grade lymphoma, but we know that especially in follicular lymphoma, it's very, very interesting tool with the same conclusion that you can see in diffuse large B-cell lymphoma. There is also data in mantle cell lymphoma that are in the same way. But in follicular lymphoma, I think it's very, very interesting.
And in T-cell lymphoma?
At T-cell lymphoma, there is, we conduct a prospective analysis with my colleague Vincent Camus and with the LISA. But I think the conclusion will be the same. But unfortunately, with the T-cell lymphoma, we do not have many clinical options. So unfortunately, usually the PET scan is not usually negative in T-cell lymphoma. So, and the clinical impact is less important because we do not have many options to treat this patient.
And is it easy to differentiate between a true negative test from an inadequate sampling?
True negative, and yes, that's a very interesting question. And also some true negative. You have to first to be sure that the pre-analytic analysis is done correctly. So I show you centrifugation, specific tube. If you do not have the possibility to centrifuge your sample in the 3 hours, the quality of DNA should be analyzed just before the NGS analysis, and after you have to discuss with your biologist and also your bioinformatician. The main thing is the bioinformatics, because there is a noise, many noise in NGS analysis, and sometimes it's very difficult to differentiate the noise and the real presence of the mutation. So it's a discussion of bioinformatics pipelines with the biologists.
You think a time has come, if the ctDNA is positive and the PET scan is negative, then one can restart the treatment, concluding that there is a relapse of the disease?
Yes, I have clearly some example of patients that clearly PET scan was negative, or if not negative, interpretation was very difficult. I show you an example of primary mediastinal B-cell lymphoma. You know, the interpretation of especially in this setting, is quite difficult. So the detection of mutation in this setting was very helpful for this patient. I say again, if you detect a mutation, you are sure that the tumor is there. But in some situation, of course, where the PET scan is slightly positive, with a very small tumors, sometimes the ctDNA is not detectable. And I have many examples in Hodgkin lymphoma, for example, that I know that the tumor was there, and we do not detect ctDNA in the plasma of our patient. So I think really you have to analyze the two tools, imaging and ctDNA, not only one.
Dr. Rajan Yadav, your question, please.
Professor, wonderful presentation. And Professor Jadad, is a question for you. Is there enough evidence today to act on end of treatment ctDNA positivity? That is, to escalate or even de-escalate in MRD negative elderly DLBCL outside of a trial? Should I repeat?
Yeah, you mean that is there any evidence today
to act on ctDNA positivity alone?
To change your strategy at the end of treatment regarding the ctDNA status?
Exactly.
Okay. There is no clear clinical trials, but you can see the curve of your patient. If at the end of the treatment the ctDNA is positive, remember the slide I show you, the Roshevsky data that were presented in the ASH in 2022. Clearly, patients that are positive at the end of the treatment relapse in any case. So why, especially in diffuse large B-cell lymphoma, why to expect? I think you have to change rapidly and, for example, propose CAR T-cell in this setting. I think for me, that's what I do for my patient.
Merci beaucoup, Professor.
Thank you.
Dr. Mehak.
Good evening, sir. Sir, excellent talk, and thank you for illustrating it with a lot of examples. Two things I have to ask. So one, in resource limited settings, if we have the option of doing a single ctDNA, what is the right time to do it? Do we do it interim, end of PET, end of the treatment, or at follow-up, or at the time of suspected relapse?
Yeah. If you suspect relapse, it's a good time. Especially if you are not able to perform a new biopsy, because I advise you, in any case, if you can, biopsy first, because it gives you more information and you are sure that of the relapse. You have the expression of CD20, for example. So if you can biopsy, it's possible. But imagine patient elderly, relapse with a situation or the biopsy is very risky. You can use ctDNA, so sure. And in the daily practice, I think if you have some difficulty to interpret your PET scan, you can also perform ctDNA analysis. And if you have only one point outside the setting of relapse, at the end of treatment, I think after 6 R-CHOP, I think it's the best situation, because if you are positive after 6 R-CHOP, you are pretty sure that your patient will relapse.
All right. So one more question. So you talked about classical Hodgkin lymphoma. What about nodular lymphocytic predominant Hodgkin lymphoma? Does it follow the same pattern, or we do go about differently because it is more indolent?
Regarding the ctDNA and POPEMA, you mean POPEMA?
So nodular lymphocytic predominant Hodgkin lymphoma.
Yes. In Europe, we say POPEMA, granuloma POPEMA. I don't know if in India you say that. I have no data regarding ctDNA in this setting, but as you mentioned, it's more indolent B-cell lymphoma than Hodgkin lymphoma. Yeah.
All right. Thank you. Thank you so much, sir.
Okay.
Thank you. There are a couple of questions related to whether there is any role in predicting graft versus host disease after a allo bone marrow transplant by ctDNA.
Very good question. It's not a setting of lymphoma, but I know that in kidney transplantation, ctDNA is related to graft rejection. Clearly, it was clearly demonstrated. So in allograft, I did some research regarding this point, and I did not see any data that the ctDNA was related to GVH. I think it was a question. So that's a good question, but you have to, if you are interested by this topic, I think it's an interesting research topic.
Thank you.
Not mine, but interesting topic.
Any other question from anybody, please? Okay. Yes, Dr. Amar Ranjan. You are muted. You are muted. Amar, you are muted.
Sir, I want to ask that there are various modes of doing liquid biopsy. So you find that the ctDNA is the best one, or any other option can be there? And the second question is that are you using in clinical practice cell-free DNA?
For the second question, yes, we use ctDNA in clinical practice. I'll show you some true example clearly. Regarding the biopsy, you mean that, I'm not sure that I understand your question, but you mean that we can use as a liquid biopsy?
Yes, sir. I want to ask a liquid biopsy. There, under the heading of liquid biopsy, there are cell-free DNA, circulating tumor cells, exosomes. So, circulating tumor cells are also under investigation, under research. So, do you find that cell-free DNA is the best one?
Yeah. We in some situation we are able to avoid biopsy, but usually we try to, of course, we perform biopsy. For example, in CNS lymphoma, we have some situation where the biopsy is not possible, and we are able to diagnose lymphoma only based on ctDNA. But to my knowledge, it's only the only situation where we use liquid biopsy and avoiding classical biopsy to diagnose the lymphoma. In the other situation, we perform needle biopsy or surgical biopsy as you do, I think.
One more question, sir. How much blood do you get to do cell-free DNA from the lymphoma patients? How many ml? How much ml?
Yeah, 10, between 5 to 10 ml to get the ctDNA, and at least the concentration of the ctDNA is around 100 nanograms.
So after completion of therapy, the same amount?
Sorry, after?
After once you complete lymphoma therapy, after that you want to do liquid biopsy or cell-free DNA. So how much volume of blood you take again after completion of chemotherapy?
We use between 10 to 20 million.
Yeah. Practically, it is very difficult to get 10 ml, 20 ml blood to.
Yeah, it's true. It's true.
Yes, sir.
Thank
Thank
you.
you. Thank you, sir.
So, friends, from biopsies to PET scan to ctDNA, this is a beautiful journey. So added in a very, very big way in our therapeutic armamentarium. As there are no more questions, I'll request Mr. Sumit Kumar to give the vote of thanks.
Thank you, Dr. Mona Vijayaran and Dr. Jardin Fabris, for sparing your valuable time. I think both talks were excellent and followed by a very, very engaging discussion. And we have many key takeaways from these wonderful presentations. Thank you so much. On behalf of Zydus, I thank Mumbai Hematology Group, Dr. M.B. Agarwal sir, for providing us this wonderful opportunity and making us a part of this esteemed academic discussion and navigating the entire webinar in a highly proficient manner. I also thank all the discussants and participants who have joined us for this webinar. Last but not the least, this series of webinar is possible only because of continuous support from Perfect Square team. Thank you so much, everyone, and have a wonderful evening.
Thank you. Thank you, sir. Bye-bye. Bye.
Thank you. Bye.